Okay. Okay, so our first activity, activity number 1 of PhysioEx number 11, deals with hematocrit. And I'm going to draw this out for you on another slide. Hematocrit is actually a division problem. We did talk about this and last week when we did our wet lab on hematocrit. Again, I gotta get my controls here. Okay. There we go. Okay, so here is my hematocrit tube. I'm not the best artist. It's difficult to draw on a vertical screen. So that is our sad-looking hematocrit tube. And we put whole blood into this tube and we spin it in a centrifuge. And when we spin it in a centrifuge, we have dense cells go to the bottom of the tube, and the most dense cells and the most abundant cells are the red blood cells. So they go to the bottom of the tube. And then I'm going to just, because I have the color here, the next band you see is a Buffy Coat. It's a white layer. And it's called the Buffy Coat, and it looks white because it has the white blood cells. And then at the top, you have the plasma. When you take hematocrit, it is a division problem. It is a ratio. You measure the entire sample, and you measure it in millimeters. So you measure the whole blood sample. In millimeters. There. Hopefully that doesn't keep chiming in. The next thing you measure is the red blood cell layer. However, that white blood cell, that Buffy Coat, sometimes is so thin, it gets incorporated into our measurement. So sometimes we say it's the packed cell volume. Packed cell volume, PCV. Now the white blood cells, even though we're measuring them maybe a little bit, remember they're about 1% or less of this entire whole blood volume. So their contribution to this measurement is going to be negligible. And in the end, it means our equation is hematocrit, this percentage, is dividing the packed cell volume, which is really the red blood cell column, divided by the whole blood sample. So I'm just going to put entire blood sample. So it is a division problem. In activity 1, you were measuring hematocrit. doing this division problem. And we were looking at a few patients. And what I want to talk about is the importance of these patients that PhysioEx selected for us. First of all, male versus female. We should know at this point that men typically are bigger creatures than females. So therefore they would have more blood volume. But additionally, men have different hormones than women in quantity. So women, we have mostly estrogen, very little testosterone. Men, you have mostly testosterone, very little estrogen. And testosterone, it turns out, drives erythropoiesis more than estrogen. So that is another reason why a man is going to likely have a higher hematocrit than a female. So that was the importance of having the two different sexes. Then why do you think it was important that we looked at people living in Boston versus Denver? Any thoughts?
Perhaps environmental differences.
Well, that's true. Elevation. So yes, environmental differences, specifically altitude. At higher elevation, if you live at higher elevation, there's less oxygen in the atmosphere. And we should know from lecture unit 1 that it is the kidneys that detect a reduced oxygen, not in the air, but in the blood. If you go to altitude and you're breathing less oxygen for a while before compensation, you're not going to have as much oxygen in your blood. The kidneys detect this change to the variable, the amount of oxygen. They have the sensors for it. And I'll remind you, they have the ability to release erythropoietin. They release the great majority of erythropoietin. So the kidneys release erythropoietin for people who live at altitude in higher quantities than for people who live at sea level. People who live at elevation are going to have a higher red blood cell count. This is secondary polycythemia. It's an adaptive response. It's secondary to a change in their environment, as Omar suggested. So if you look at your results, you should have seen that the male had a normal range of hematocrit. Normal range is different for females and males. And our class number that we ask you to know is 45%. So the male was a little bit higher than that. The female was a little bit lower than that, but they were still in their normal clinical range. The healthy male living in Denver had a higher hematocrit than the healthy female living in Denver. Okay, so there's our sex, male versus female issue. But those two living in Denver had a higher hematocrit than the male and female living in Boston, and that's because we see this as secondary polycythemia, an adaptive response. Should we do anything to these two individuals in Denver? Should we try and cure them? No, we should see this as an adaptive response. If they came down from Denver and lived, say, in Huntington Beach, their EPO levels would gradually go down. Their red blood cell counts would gradually go down. Again, the environment provokes changes in some sort of variable, in this case, oxygen carrying capacity, and the kidneys are detecting that. Our last two patients are patients with anemia, and we had a patient with aplastic anemia. With aplastic anemia, we should know that this comes down to a stem cell failure. Erythropoiesis is not only abnormal, dysfunctional, but so is hemopoiesis. which is the synthesis of all the formed elements. And you should have seen that this individual not only had reduced hematocrit, but reduced white blood cell count and platelet count. Well, we didn't actually measure platelet count, but they would have. Then lastly, the female with iron deficiency anemia. We hopefully remember that iron deficiency anemia generates red blood cells that are microcytic and hypochromic. And this means her hematocrit is going to be lower. Why? Look at the equation. If we are dividing the red blood cell column, PVC, packed cell volume, which is mostly the red blood cell column, and that red blood cell column is now smaller. If your numerator is going down because the red blood cells are smaller, and it's going down more than the entire height of the whole blood column, we're going to get a smaller average, percentage, sorry. So her hematocrit was lower. Her white blood cell count was still fine. It's her red blood cells that aren't being made right. That's why they're microcytic and hypochromic. Are there any questions about this activity, activity 1? Okay. Then let's move on to activity 2. And in activity 2, you were looking at erythrocyte sedimentation rate, or ESR. In a clinical setting, we oftentimes just call this SED rates. How do we do a SED rate test? Well, over here in this bottom right picture, you are reminded of the apparatus that you were using. And on the next slide, insert slide. Let me draw that for you. Again, I have to move all of my controls, so just bear with me. There is no easy way to do this. There. Okay. What we did was, again, we took a tube. This was a much larger tube than the hematocrit tube. And it's bigger, it holds more blood. And all we do is we pour whole blood, an entire whole blood sample into the tube. The tube has a ruler associated with it. At the top of the tube, it's 0 millimeters. And it's usually in increments of 10. So we fill the tube with the patient's blood. If we were face to face, you would be doing this with my blood. So the blood is filled to the top of the tube, to the 0 millimeter mark. And you let the blood settle, sit there for 1 hour. And when you come back after an hour, this is what you might see. You might see that the red blood cells fell to the bottom of the tube. Why do they do that? There are more of them. They are more dense than the other formed elements, so they fall according to gravity faster than the other elements. And at the top of the tube, you would still have your plasma. So in my example that I've drawn here, this person had a SED rate of 20 millimeters per hour. Let's say after an hour, another patient had this result. The second patient would have had a result of 10 millimeters per hour. The patient that had 20 had a faster sed rate. Their red blood cells settled more quickly. The patient on the left had a slower sed rate. What do sed rates tell us anyway? Really nothing truly diagnostic. Rather, they're quick, they only take an hour. They're cheap, all you need are plastic tubes and a ruler. But they can give us some information. We can still compare a patient's sed rate to a normal range. There are different sed rates, of course, for men versus women, children even. Sed rates can also be helpful to us because we can get really fast sed rates whenever red blood cells make what's called a Rouleaux formation. So I'm going to draw a Rouleaux formation for you at the bottom right of this picture. With the Rouleaux formation, red blood cells start to stack on top of each other like they're a roll of coins. Have you ever purchased or went to the bank to get a roll of coins? Maybe you do your laundry at a laundromat and you went to the bank and you paid $5 to get a roll of quarters. Well, red blood cells can stack like that as well. This is not a clot. It is not. Clots come from platelets. This is called a Rouleaux formation. Now, what's the importance of this? And why can it impact a sed rate? I don't know if you've ever walked by a fountain. You know, the water features that you might see in front of buildings like museums and things like that. Well, when you walk in front of these big fountains, you might look into the water and you might see coins that people have tossed into the fountain, making a wish, thinking something like that brings them good luck. Let's say you toss in a penny. 1 penny. Now, pennies are pretty heavy. They're certainly more dense than water. You toss in this penny, and you might have been surprised that the way you threw it in, instead of just kerplunking to the bottom, it might have feathered through the water. Feathered through the water. And if you went to the bank and got a roll of pennies and threw the entire roll of pennies into the water, of course that roll of pennies would have just went boom, straight down to the bottom of the fountain. I want you to think of that analogy as we go through the data for our data set. Just hold on a minute. I'm going to close my window. It's 92 degrees in here and I don't want to close my window, but I also don't want to keep hearing a dog barking in the background. So when red blood cells are individual, like an individual penny, they kind of feather their way through the column to the bottom of the tube. But when they stack together in the Rouleaux formation, they fall much more quickly. The question now is, what can make red blood cells stack like this? And by the way, this is not agglutination. It is not red blood cells being attacked by antibodies. This is something different called the Rouleaux formation. There can be proteins there are, not can be, there are proteins associated with an inflammatory response. When tissues become damaged, they are inflamed. And they release proteins. They release chemical signals called cytokines. Distress signals. Hey, we need help, if you want to think of it that way. So some of these inflammatory proteins, one, and you don't need to write this down, but I'm going to. One is called C-reactive protein. So these distress signals, these proteins that are released when tissues become damaged and they're going through the inflammatory process, these proteins can actually link, binding to receptors in the red blood cells. They kind of link them together. And that's how we get our Rouleaux formation. If we see someone with a very fast SED rate, we start to think maybe it's the Rouleaux formation. What sort of cell damage, tissue damage are we seeing here? If someone, say, has an autoimmune disorder like rheumatoid arthritis, for sure that person has tissues that are being attacked by their immune system. And as the tissues are being attacked, they release these distress signals. During a flare-up of rheumatoid arthritis, a person is going to have a faster SED rate. In lecture unit 1, you learned about the advantage of giving people with these types of inflammatory disorders high levels of cortisol. And you learned that cortisol reduces our immune response. So if a person has a flare-up of their rheumatoid arthritis, and we see a faster SED rate, and we start giving them the cortisol, what we should see is their SED rate improves. Less Rouleaux formation. That is another way we can use a SED rate. We can use it to monitor if a patient is having a provoked inflammatory response, and then if we give them medication, is their inflammatory response being tempered and their Rouleaux formation is less, therefore their SED rate is slower. So we can use it to monitor the progression of the disease and disease management. Do you have any questions about the uses for SED rates so far? You're very bored. You could care less. You're starting to evaluate your career choices, and maybe you want to pursue something totally different, like art. No? Okay. Well, then I'm going to click back to my other slide. And now let's go through our data. Now that we have an idea of what a SED rate looks like, the Rouleaux formation, what can trigger the Rouleaux formation, inflammatory issues where tissues are under distress, and those inflammatory proteins cause red blood cells to link together. It is not a clot, and it is not agglutination. It's something different, Rouleaux formation. So we were looking at a healthy individual. We're not told if it's male or female. And we noticed that they have a SED rate of 5 millimeters per hour. Then we look at a menstruating female. Now, arguably, you might start saying, well, she should have fewer red blood cells. And maybe that's why they're settling to the ground, or not the ground, the bottom of the tube faster. Yeah, less traffic of red blood cells. That's one reason. And I have another reason. And it actually, before I got to my other reason, a student, and I won't tell you I won't tell you the sex of this student, but I bet you can predict. A student, before I could explain another reason why a menstruating female would have a faster SED rate, this student said, well, I know menstruating females, and boy, do they get inflamed. They get inflamed over everything. They make something big out of nothing. They're just inflammatory in general. And we all had a good laugh. And I said, you know, he's not entirely wrong. Yes, that is tissue that is dying. And even though it's normal and we're sloughing off half of our uterus into the toilet, ladies, the remaining tissue is also experiencing some of this damage. It has to rip off from the underlying layer that will repropagate, of course. So there is some inflammatory markers, proteins, that are released into our blood. And there is more of a Rouleaux effect when we are menstruating. So remember what that student said, they're inflamed. They're inflammatory to everyone. Well, it's not an outside Rouleaux effect, is it? It's inside. So that's why she has a faster SED rate. Now we have a patient with sickle cell anemia. And this one, anemia, we think reduced oxygen carrying capacity. And we would think, well, Kara, you just used, if there are fewer red blood cells, less traffic and they can get to the bottom faster. Yeah. Well, what about sickle cell anemia? What about it? In this experiment, we are to assume that these cells are sickled. Not all of them, but a great proportion of them. And when they are sickled, we know that means they're crescent-shaped, half-moon shaped. And they're not going to fall to the bottom of the tube as readily. They are going to kind of get in each other's way. They are going to take more time feathering through because of their crescent moon shape. And in this person, after an hour, we didn't see any of those cells getting down to the bottom. We didn't see any plasma up at the top. So the shape of the red blood cells prohibited them from having this gravitational fall towards the bottom of the tube. What about iron deficiency anemia? Okay, now we have microcytic, small red blood cells. And in iron deficiency anemia, we also know we aren't making as many because we don't have enough iron. So we have fewer red blood cells getting in the way, and they're smaller, and they are falling to the bottom of the tube at a faster rate. This person has a faster SED rate. Now, patient 5 and patient 6 are interesting. Pretend we have patient 5 and patient 6 both presenting in the emergency room with chest pains. Turns out one of them is having chest pains due to a myocardial infarction, but we got to figure that out. In a myocardial infarction, there is reduced blood flow to a section of the heart through the coronary artery. The cells in this region of the heart are ischemic. That means there's reduced blood flow to them. Maybe there's a blockage, an atherosclerotic plaque in the left coronary artery, let's say. Reduced blood flow means the cardiocytes are getting reduced oxygen delivery. Then that means the cells are becoming hypoxic, anoxic, which means no oxygen. And if those cells don't have oxygen, then they cannot perform aerobic respiration. They do not make as much ATP then. And the cell's metabolic processes are impaired. The cells start to die. And as those cells die, they send out the distress signals. And when tissues die in this fashion, this necrotic fashion, it is not pleasant, and there's pain associated with it. That's the reason why this person is presenting in our ER with chest pains. But just because you have chest pains doesn't mean you're having a myocardial infarction. You can have chest pains because maybe you've been sick and you've been coughing a lot. And when you cough a lot and strongly, you use your internal intercostals. And muscles that are used over and over and over and over again when they normally aren't. For a normal exhale, you don't need them. But for a forced exhale, like a cough, you do. Muscles that are overused, what happens to them? They get sore. They get fatigued. They get lactic acid building up in them. And it hurts, doesn't it? Ever wake up one day saying, hey, I'm going to get in shape. I'm going to run 6 miles today, and you've never even run 3 inches in your life? How sore are you going to be the next day and the day after? It hurts, but it doesn't mean you're having a heart attack. So these two people show up with chest pains. We need to evaluate them. What we evaluate, what our data comes out, will dictate how we treat them. One of the tests we do is a SED rate. Notice that the patient who has chest pain, they have angina pectoris, that just means chest pain. They have a SED rate of 5 millimeters per hour, which is like the normal person in sample 1. But the person having a myocardial infarction has a much faster SED rate. Why? Distress signals. See reactive protein, for example, causing a Rouleaux formation. So now the question is, do you honestly think that we would only use a SED rate to determine if someone's having a heart attack or just good old-fashioned chest pains? Do you think we would only use this test? No. We, of course, would use other tests, like hook them both up to an EKG machine and look at their EKG profile. By the way, we will be analyzing EKGs when we get to Lab Unit 2. You will learn a lot about EKGs. So that is also another non-invasive test, very quick, and definitely gives us a snapshot of what's happening in the electrical conductance of that person's heart. If they are having a myocardial infarction, we can see changes in it, most certainly. But guess what? Some people with chest pains that aren't having a heart attack can also have changes in EKGs. Different kinds of changes, and that's where the interpretation is important. You will learn how to interpret a few things in EKGs, and we're getting there soon. Another test we would do is another blood test. Turns out cardiac muscle, being cardiac muscle, uses different kinds of troponin, one of the proteins found in the thin filaments. A unique troponin compared to troponin used in skeletal muscle. So if this person is having a heart attack, and if these cardiocytes are becoming damaged, some of their cellular contents are being liberated, sort of like the cells are just going bleh with their contents. And we would detect that troponin in their bloodstream. It shouldn't be in the blood, it should be inside the cardiocyte. So you see, we definitely do more than one test to confirm these signs and symptoms into our diagnosis of you're having a myocardial infarction, not just a SED rate. I point that out because some students in the past have said, so all we have to do is a SED rate to know if you're having a heart attack. No, No, we do much more than that. More than one test. Are there any questions about this activity?
Yes, Carl.
Yeah.
What were the other tests we could use again, aside from EKGs?
This blood test for troponin.
Open.
Troponin.
Thank you.
Yep.
Uh,
And there are
the
others.
only
Go ahead.
the only reason why the last person with the angina pectoris had a slow sed rate is simply because they're just having normal chest pain.
Yeah, so they had a normal sed rate compared to the normal person in sample 1. So they're having chest pain for some other reason.
Okay.
Maybe they have, like I said, a muscle cramp in their internal intercostals. And that might sound, Selena, that might sound preposterous. But this actually, the reason why I use that example is because that happened to my sweet husband. He was on blood pressure medication. And you will learn about this particular blood pressure medication later on in the semester. But one of the side effects in about 10% of the people prescribed this blood pressure medication is they develop a chronic cough. So this blood pressure medication was causing his mucous membranes in his lungs to create this cough reflex. And so he was coughing all the time. And he kept having this nagging sensation that he needed to clear his air passageway. So he kept coughing. And his muscles, his internal intercostals, became fatigued. He calls me at work and says, "I'm having chest pains. I just called the doctor to make an appointment to go see my doctor." And I'm on the phone like this. "You're not going to go see the doctor." And he said, "Yeah, that's what they told me too." I said, "You don't call your doctor and say, 'I'm having chest pains.' And they say, 'Would you like to come in at 3 o'clock today?' No, that's the golden ticket. You go straight to the emergency room. And when you get to the emergency room, when you walk up thinking you're going to wait 3 hours, turns it. When you say, "Why are you here?" and you're filling out your paper, "I'm having chest pains." Pretty much you don't even get to finish your paperwork. You are triaged. You golden ticket winner. You go, because they need to figure things out quickly. They're not going to have you wait 3 hours. So that actually happened to my husband. I start leaving work. I dismiss my class thinking my husband's having a heart attack. I go home to get clothing for him because I think he's going to be there for a while. He does have heart disease in his family, even though he's the epitome of health. He does have that. I get to the hospital. They're disconnecting him from the EKG. His blood work comes back, and the doctor and nurse are explaining to him that the EKG looked normal, blood work came back normal, that he was probably this 10% having a reaction to the blood pressure medication he was on. He went home, changed his blood pressure medication, just fine. And this is what my darling husband said to me as we left the hospital. "I feel like an idiot. If I have chest pains again in the future, I'm never doing that again." And I went, "Yes, you will." That's what you do. You're not an idiot. How did you know? They know what to do. So, yes, angina pectoris, chest pains. Again, we wouldn't just rely on a sed rate to distinguish between a heart attack versus chest pain from something else, like a fatigued muscle. Okay? So there you go. That was a true example. Okay, activity number 3. Well, this is an activity that we did differently last week in our wet lab demonstration. We used the Tallquest test. And in the Tallquest test, I showed you this square piece of paper, and I said, you would come up to me with your piece of paper, and I would squirt my blood on that piece of paper, and while it was still wet, you would look at the color of my blood and match it to the color swatch. Remember that color swatch, and you all had to match the red. And last week I said, you're going to do this again in a PhysioEx, but you're going to use a different technique. You're going to use a hemoglobinometer. And it still was color-based. You had to match not red colors, but green colors. And you move this little lever until the two halves of the circle had the same matching green colors. So you were measuring hemoglobin grams percent, and I'll remind you that means the number of grams over 100 milliliters of whole blood. In lecture, and this is the number I want you to know, in lecture I told you a normal range was 14 to 16 grams percent. That's the range I still want you to know. However, we should know at this point that females and males will have a slightly different range, and the actual clinically acceptable range is a little bit wider than this. I want you to remember 14 to 16 grams percent for your lab exam, please. And again, we had some patients that we were looking at. Please do not worry about the data you wrote in the third column. Do not worry about ratio of PCV to HB. Why don't I want you to worry about that? Do you even care? Short answer, it is a volume to mass ratio. PCV, packed cell volume. HB, grams of hemoglobin. In lecture, I gave you a different mass to volume that I wanted you to know for red blood cells. And that's the one I want you to focus on for lab because it's even in your lab notebook. What was that different mass to volume ratio? It looked like this. Mean corpuscular hemoglobin mass, the amount of hemoglobin in a single red blood cell, divided by the volume of a single red blood cell, gave us a ratio, a percentage, called mean corpuscular hemoglobin concentration. That is the mass to volume ratio I asked you to know for your lecture exam, and it is still in your lab manual. PhysioEx was giving you a different way to express this mass to volume ratio, and I don't want you to worry about two different ways. So please stick to this MCHC equals MCH over MCV. That means the last column, PCV to HB ratio, you don't need to worry about. The middle column, hematocrit, you don't really need to worry about because we've already discussed a PhysioEx on that. That was activity 1. We know what hematocrit is. Let's just look at the grams percent for these patients. We had a healthy female and a healthy male. Both of them were in our class standard range of 14 to 16 grams percent. Then we had a female with iron deficiency anemia. Female with iron deficiency anemia. Her hemoglobin grams percent was roughly half what it should be. Her red blood cells, she's making fewer of them and they're smaller. They're not as well filled with hemoglobin. Now, weirdly, a lot of people are surprised to find out that that's roughly what your hemoglobin grams percent falls to, almost half of what it should be, before most people start to say in their head, I just have not been feeling well. I feel tired all the time. Maybe I should go see my doctor. Oftentimes that's how far it drops before someone starts to say, there's something going on. I need to go figure this out with my doctor. And then our last two samples, we have a male with polycythemia. Okay, we've talked about polycythemia already tonight. We've talked that men typically have more blood than women. So now we have a man with a lot more blood. We're not told what kind of polycythemia he has. Could be vera, primary, or secondary. We don't know. We don't care, because all we know is his hemoglobin grams percent is elevated like we would predict. Why is this interesting when we compare him to the female Olympic athlete? She's female. He has polycythemia and he's male. What do you notice about her hemoglobin grams percent?
It's elevated.
It's elevated. She has more than a man with polycythemia. What do you think she's doing? Any ideas? Do you think she's training at elevation? I don't think so. I think being the female Olympic athlete, she's probably doing steroids. Maybe she's doing anabolic steroids that are giving her more testosterone-like responses from her hemocytoblasts. And she's making more red blood cells. Why? To give her an advantage. Maybe she's a runner. The longer she can, the more oxygen she can carry, and the more time she's in aerobic respiration, it might mean fractions of a second cut off her time. She's faster, and she wins. So that was why PhysioEx put her in, along with the male with polycythemia, to invite this discussion of, you see a hemoglobin grams percent like this in a female that comes out higher than a man with polycythemia, you start to ask some questions like, what are you doing? Something's going on here. Are there any questions?
So a female Olympic athlete who doesn't take steroids wouldn't be able to get a higher percentage than a male?
Not even if she were at altitude. Not even if she were at altitude. And it's funny to me. I don't know. Selena, there have been a few times I've talked to you where you have said, I'm going to go for a run. Right?
Yeah.
And were you a runner in high school? Did you?
No, I played volleyball in high school, and then once I went to college, I started running.
Okay. Well, in high school, my boys had friends that were on the track team, and during summer, these kids, their parents would pay a lot of money for them to go to camp during the summer, right? To train. And where would they go train? So during the summer, they would go train in Mammoth. And they would spend 1 week training in Mammoth to improve not just their lung conditioning, but to, quote, give them, this is what their coach said, to give them an advantage on the track. And so I'm thinking in my head, this is summer when they're doing their training. When is track season? At most high schools, it's not until like winter time. So how is 1 week of training at altitude, number one, really going to make you have this huge advantage? Because most people have to acclimate for at least 2 weeks. And then still you're at a given altitude. You're not training at the top of Mount Everest, for crying out loud. And then you come down off the mountain and you don't have your track meets until 4 months later. I didn't have the heart to explain this to the parents that were shoveling out so much money to have this happen, because they really honestly believed that they were being really good parents by giving their children an advantage for these competitions that were months later. I didn't have the heart. But I laugh at that. And some people I see on the street, and I was wondering if it was you, that's why I asked. When they run, they wear masks. Have you seen this? They wear these, and it's not even COVID masks. They are wearing these masks that make it very difficult for them to get air.
Yeah, they're intense.
I know. And I see them wearing this at the gym, and I can't help myself. I go like, why are you wearing that? That's interesting. Is that something I need? And they're like, well, if you're really training and you want to be able to get more oxygen during a competition, when you're not wearing this mask, you're going to be at an advantage. And I'm like, so are you wearing this all the time or just when you're training? Oh, just when you're training. It's too hard to breathe when it's all the time. And in my head, I'm thinking, the kidneys in no way are going to start spewing out EPO just because you're wearing this mask during training for what, an hour, 2 hours? It's not going to happen. It's not going to happen. It's not going to happen. But I just let them believe that. I'm very entertained when I go to the gym, but I haven't been for forever because, well, COVID. Even though they're opening up, I don't trust them. Not yet. So we're going to move on to blood typing, and I would like you to take a 10-minute break, and I will start drawing my pictures that I drew for the Monday, Wednesday class for you. So go take a break. I'll see you at 7:25. Come back to me and I'll have most of my pictures drawn so that we can go more quickly and be done for the night. Okay? Go have a break. All right, so we are moving on to our blood typing last exercise in our PhysioEx11. Let me explain to you what I've tried to draw up here. Up here in the top left, you're seeing a red circle. This is to represent a red blood cell. Sticking through the red blood cell are black lines with a blue letter A attached to the black lines. That letter A is to represent the A sugar. If you are blood type A, you have the A sugar sticking out of your red blood cells. The name of this sugar, the proper name, is called N-acetylgalactosamine. The green squiggly line that you are seeing woven through the red blood cell is representing a different antigen, a protein, not a sugar. And this woven line represents the protein called Rh factor. When we blood type a patient, we don't know what sugar they have or not. And we don't know if they have the Rh factor or not until we blood type them. This middle picture here, in the middle, that I'm drawing an arrow at, is my pathetic way of drawing a glass slide. You know, like a microscope slide. And I have taken the same red blood cell picture and I've put it on this slide 3 times. This is to represent the 3 blood drops we would put on the slide when we're blood typing a patient. You, the healthcare provider trying to blood type this person, you now add antibodies to the blood samples. To the first one, you will add anti-A antibody. You drop it on the patient's blood drop. To the second blood drop, you add anti-B antibody. And to the third blood drop, you add anti-RH antibody. Sometimes anti-RH antibody is also called anti-D as in dog, or anti-Rho, meaning RHO. So it has different names. Let's, for a moment, just jump to the next slide. And by the way, I will be saving these slides and posting them. So if you're frantically trying to draw and I'm going too fast, don't worry, I will be saving them and posting them for you. Let's explore these antibodies that I have drawn at the bottom of the screen of the slide in a little bit more detail. Before I go to the next slide, I want you to pay attention to their binding sites. These antibodies that I've drawn represent your typical IgG, immunoglobulin G. It has this typical Y-shaped appearance, and at the end of the Ys are the binding sites. I've drawn the binding sites in a different shape for all 3 of these antibodies for a reason. To represent that the binding sites are specific. Antibodies recognize one antigen. And believe it or not, the way they recognize it is by binding. This binding only occurs if the antigen fits. It's sort of like Cinderella with a glass slipper. Her evil stepsisters didn't fit their big feet into this tiny glass slipper. Antibodies are a lot like that. Their binding sites are very specifically shaped to interact with the antigen they have been made for. So I've drawn their binding sites differently. On the next slide, here they are again. Here's my anti-A antibody, and I drew its binding sites, kind of silly, to represent that it could bind to the A sugar. A is pointed, so I drew its binding sites on the antibody like a V. So the pointed part of the A could bind, would fit. Anti-B antibody, I made its binding sites almost look like 3s. And that was to, my lack of humor, but I try, show you that a capital B could fit in those binding sites. Now, anti-B antibody recognizes the B sugar. What is the B sugar? If you are blood type B, your sugar sticking through your red blood cell is called galactose. The RH factor that I drew on the previous slide was a green squiggle. So I drew the binding site for the anti-RH antibody as a black squiggle. These 3 antibodies are drawn binding to their particular antigen. And if they bind to their particular antigen, I want you to think of this, that antigen is still stuck to our red blood cell. And when we get a whole bunch of red blood cells stuck to antibodies, and this is an immune reaction. When you have antibody plus antigen, and it's a blood antigen, you get agglutination. And when this happens on our slide, when the antibodies recognize their antigen and they make these big complexes, they get very bulky because antibodies are linking to these red blood cells. It precipitates out of solution, and we will see spots appear on our slide. That's agglutination. It's showing you a whole bunch of antibodies linking to all of these red blood cells. So let's go back to our slide. We are trying to blood type this patient. You add anti-A antibody to the first blood drop. Will the anti-A antibody find its antigen? Will it bind to it? Is it a match? Then what will we see? Agglutination. And we're going to see on our slide all of these spots appear on our slide. To the second blood drop from the same patient, you add anti-B antibody. Will this anti-B antibody find any B sugar? Is there a B sugar present? This patient does not have B sugar sticking out of its red blood cell. Will we see agglutination? No. What about with the anti-RH antibody? Will this antibody find its antigen?
Yes.
And we will see agglutination, won't we? And therefore, this person we have just blood typed. We say they are A positive. We give them the letter A because they have the A sugar and acetylgalactosamine, which reacted with the anti-A antibody. We say they are plus because they have the RH factor. Let's do another example. It's always the same system, okay? If it's not a slide, it's a blood typing card. You put 3 drops of blood. And to the first one, you always add anti-A. To the second one, you always add anti-B. And to the last one, it's anti-RH. What blood type do you think this person would be if you saw this?
AB positive. AB positive.
Correct. When you watch my blood typing lecture, if you haven't already, you might hear me say, one of our cute sayings is, you are what you clump. So if you clump with anti-A, the only way you could have agglutinated and formed those clumps is if you had the A sugar. You are what you clump. If you clumped with anti-B, then you have the B sugar. If you clumped also with anti-RH, then you have the RH protein, and you would be AB positive. What if you saw this? In case you're wondering, I am finished drawing the next example.
O negative.
O negative.
Correct. It would be O negative. O negative. O negative people do not have the A sugar, they don't have the B sugar, and they don't have the RH factor. That does not mean that O negative people lack any other antigen on their red blood cells. Look, there are other antigens, other things sticking through your red blood cells that could provoke an immune reaction if you donated them to someone else. Why don't we care about these other antigens? Why aren't you being abused with antigen M and N and S? They do exist, but they're more rare. These antigens, the A sugar, the B sugar, and the RH factor, are more clinically important to us because they are more common and they do provoke an immune response more quickly if you give a blood transfusion to someone and you don't blood type them correctly. If you mismatch the blood they should have received. So these are our focus clinically and in our class. This means there are 8 blood types you need to master: A positive, A negative, B positive, B negative, AB positive, AB negative, O positive, O negative. 8 standard clinically important blood types. If you take a genetics class, you will likely learn about the other antigens, other blood types that are more rare. If you take pathophysiology, you will also likely learn about other antigens that are more rare. But that's not for this class. So let's move on to our experiment. We had 6 different patients and we had to blood type these patients. In the interest of time, because there's a challenge I want to give you, let me just tell you what blood types you should have detected in these 6 patients. Patient 1 should have been A positive. Patient 2, B positive. Patient 3, AB negative. Patient 4, O negative. Patient 5, AB positive. And patient 6, B negative. Many of you have already emailed me your PhysioEx number 11, which is due tonight by 11:59 p.m. Some of you have not. Maybe you haven't gotten around to completing the exercise yet. Those of you who have finished it, did anyone get a different blood type than what I just called out? All right, so here's my challenge. This is my challenge. I just told you what blood type these 6 patients are. And you don't have to do this challenge, but if you want to feel good about blood typing for your lab exam that is coming up, this challenge you should accept. Because on your lab exam, not only will we ask you, what blood type is this person? And we're going to tell you where you see agglutination and where you don't. That's pretty easy. But we will also ask you what agglutinins will be made. Agglutinin is another word for antibody. So in this challenge, this column, I want you to tell me what antibodies this person would be making. Should a person with blood type A positive make anti-A antibodies? Should you make no? That would be not compatible with life. You shouldn't make antibodies against yourself. That's an autoimmune disorder, right?
Yes.
Should this person make an anti-RH antibody if they have RH factor? No. So let's just do a few of them. What antibodies would this A positive person make? They would make anti-B. Good. And the B positive person, they would make anti-A. What about the AB negative person? What antibody would we find in their plasma? Neither anti-A nor anti-B, but they would be making an antibody to something. Anti-RH. Because they don't have RH, we would assume they would be making anti-RH. And for those of you who have watched the blood typing video, you know that this RH factor is not as antigenic. That means it's not as likely to provoke an immune response. But look, if someone is exposed, if someone is RH negative and they're exposed to RH positive blood, maybe they won't have a severe reaction at first, but if they keep getting exposed, it could get bad. If you're my nurse, if I tell you I am RH negative and I need a blood transfusion, and you come to me and say, all we have is RH positive blood with your sugar type, but all we have is RH positive blood. Kara, have you ever had a blood transfusion before? And I say, I don't think so. Not really sure. I don't remember. I mean, I've never had one as an adult, but I don't know. As a kid, I don't know. I had surgery. That's true. When I was 5, but I don't know if they gave me a transfusion. If you're my nurse and you go, okay, even if you did that one time, you should be okay. How dare you assume how strong my immune system will respond or not? You don't know. So a positive can receive both positive and negative type bloods. But a negative person, you always assume they are sensitized. You assume they have been exposed, and you assume the worst. You assume they have that anti-RH antibody ready to go. And in my lecture, I make a kind of tongue-in-cheek joke over that to make a point. How dare you assume something? It's better to be conservative and assume your patient is ready to launch this immune reaction, and that means you better get this blood transfusion right. That's the safest way to be as a nurse, isn't it? What about the O negative patient? What antibodies will they have?
They have both.
They have both anti-A,
B.
anti-B, you are correct, but they would also make
RH positive.
so they would make anti-RH antibody. Yes, they make the antibody against the RH factor. What about this AB positive patient?
They don't any antibody.
They won't make any, will they? Not to these antigens, not to these antigens that we're clinically worried about. And then lastly, the B negative person would be making anti-A and anti-RH. Okay, so I've done the first challenge for you. The second two columns continue with the challenge, and I'm not going to fill them all in for you. In the next column, it says, what blood types could this person safely receive? So again, we're talking about our patient. Let's do patient 1, who's A positive. What blood type could they safely receive? And because they make anti-B antibody, you better not give them any blood product that has a B antigen. So anything else would be safe, right? We can give them A positive. We can give them A negative. We can give them O positive and O negative. And right about now, a student says, Kara, I know I can give them A positive and A negative, but why O positive and O negative? Won't the O positive and O negative patients have anti-A antibody in their plasma? You are correct, they would. However, we do a very important procedure before we give a person a blood transfusion. We take the donor's blood and we spin it down. Remember, a centrifuge can separate the red blood cells from plasma. We saw this when we learned about hematocrit. If we remove the plasma from the donor's blood that they donated, and then resuspend the red blood cells in isotonic saline solution, and then give the blood transfusion to the patient, it gives us more options, doesn't it? It gives this patient, this blood type A positive patient, 4 safe options now. Obviously, getting as close to the patient's actual blood type is better. So instead of only getting A positive and A negative, now this person can also get O positive and O negative. More options is good, especially when there are frequently blood shortages, aren't there? What state do you live in? This is not a hard question, so hey, everyone can participate with this.
California.
California.
I mean, not all of you may be living in California right now, right? This is online right now. So most of you, I do know, you are living in California. Congratulations. You are living in a very densely populated state. You are living in a state with the highest consumption of donated blood. And you are also living in a state with the fewest blood donors. Sounds about right for California, doesn't it? The most greedy state? We take, and not many of us give, at least when it comes to blood. So having these extra options, safe options, are desirable. What about patient 4? Let's do one more. Patient 4. What can patient 4 receive?
None.
Well, so thank you for saying that. They can receive O negative, can't they?
Yeah,
So,
they can.
So strangely on exams, the number one overlooked blood type that a person can receive, that a student usually forgets to tell me, is the person's own blood type. Isn't that funny? But it happens. Number one. So O negative people can only receive O negative blood. Sucks to be them, huh? Well, how about AB positive? How about patient 5?
All of them?
All of them. All 8.
All of them.
All 8. And that is the reason why we say AB positive people are the universal recipients. Universal recipients. And again, it still comes down to we centrifuge. We centrifuge out those antibodies from the donor's blood. That gives us all of these options that we're talking about. Now, last challenge, and I'm going to do fewer. Who can these people donate to? Sometimes when people give a gift or get a gift, like a donated blood, they want to give back. Seems only right. Give back, pay it forward. Who can the O negative person donate to?
Only O negative?
Negative.
They can donate to all blood types. And that is the reason why they're called the universal donor. Again, they don't have an A sugar, they don't have a B sugar, and they don't have the Rh factor. Before we give anyone O negative blood, we remove the antibodies from their plasma before we give the blood to the recipient. And that way, the O negative blood from the donor does not attack the recipient's blood. Again, centrifuging the blood is the key.
Sorry, I have a question. What about O positive? Is that the same with O negative or?
No, O positive could only give to positive blood types. Because
Okay, all positive.
only the positives, because the O and O positive has the Rh factor. And what about the AB positive person? Who could they donate to? Only AB positive. That's the only person they can donate to. So isn't it ironic? AB positive people, you're the most greedy people. You can take everybody else's, but you only donate to one. And poor O negative people, they're the givers. They give, but they only get one back. Now, if you are AB positive, I am not saying you really are a greedy person. I am just making a joke. Don't take it personally. It's just me having fun. Anyway, so try and fill in the rest of those columns if you want. And if you do and you want me to check your work or have a conversation about it during office hours, I am happy to do so. Are there any questions about blood typing? Okay, so I've done an amazing job, or your tutors have done an amazing job, or you've already watched the blood typing video and have figured it out. Either way, I'm glad. I'm glad. Or maybe you really haven't thought about it too much and you feel a little shy to ask. Well, maybe you can email me your question and we can meet up on Zoom during office hours and you'll be more brave then to ask. On that note, I'm finished talking about the PhysioEx and blood typing. There are more blood typing problems in your lab manual that you should look at. And there are other blood type issues that were talked about in the blood typing lecture, like hemolytic disease of the newborn. That is clinically important. This is a special consideration when a woman is Rh negative, and statistically speaking, she's likely carrying an Rh positive baby. There are things that we want to be mindful of in that situation. Ways we can prevent HDN, hemolytic disease of the newborn. If a baby is born with HDN, there are ways we treat the baby for this problem. And you really do need to pay attention to that part of the video. So if you haven't watched that yet, you should. Your lab exam is coming up. And like I said, there are practice problems in your lab manual, which means they're not optional. You're still turning in your lab manual. You're filling them in, but they are there to give you practice on these concepts. So please look at them. Okay, well, I hope to hear from you either through email or text if you're interested in meeting with me to go over your lecture exam. We will set up an appointment that is mutually acceptable to both of us. It may take me some time to get to you because I'm going through 3 classes right now trying to do this with people that want to. So that's about 90 students. And if each one is taking approximately 20 to 30 minutes, it's taking some time, but I'm happy to do it. And you won't be waiting until December for this. My goal is to get through everyone who wants to get through by hopefully mid next week. I mean, I still need to sleep. You still need to sleep. We've got jobs. I have teaching, but I will get to you all if you want that time with me. And again, I'm happy to do it. So